All right, why don't you guys go ahead and start?
All right, sounds good. So hello, everyone. My name is Morgan Mazars, and this is the first journal club of the 2022-2023 school year. So this today we're doing a presentation. So it was me, Jasmine, and then Shariza with the help of her. We did an article. So can you go to the next slide? Okay. So we did the effect of spironolactone on morbidity and mortality in patients with severe heart failure. So this was a historic study. It was done in September of 1999. So we're going to be looking at some of the things, some of the things in this study. So to start off, what is heart failure and what causes it? So heart failure occurs when the heart can't pump enough blood and oxygen to support other organs in the body. So essentially, the heart can't keep up with its workload. And at first, the heart tries to make up for this by enlarging for one. So the heart stretches to contract more strongly and to keep up with the demand to pump more blood. And then over time, this causes the heart to become enlarged. And then another attempt is that the heart tries to develop more muscle mass. So it increases its muscle mass. This occurs because the contracting of the cells make the heart get larger. And at first, or initially, this lets the heart pump more strongly, but over time, this takes a toll on the body. And then another attempt that the heart tries to compensate for this overworking load is to pump faster. So this helps, the heart with the heart's output. But this can't last forever, right? So this will have an effect on the body. So some of the common causes of heart failure include coronary artery disease. So this is when cholesterol or fatty deposits build up in the heart's arteries. And I'm sure most of you have heard of atherosclerosis. So that's the buildup within the arteries, and this can increase blood pressure, which can also lead to heart failure over time. And then another cause would be a past heart attack or a myocardial infarction. And basically the damage of a past heart attack damages the heart. So it can't contract as well, and it makes it more difficult for the body or for the heart to pump more blood efficiently. And then another cause is high blood pressure in general. So uncontrolled high blood pressure is a major risk factor for developing heart failure. And the heart has to pump harder than normal to keep the blood circulating. So this takes a toll on your heart and the chambers, and it becomes larger and weaker over time. And then another cause would be obesity. We know that the heart has to work much harder for an obese person compared to a non-obese person. Another cause would be abnormal heart valves. So when the valves either don't open or close properly or completely during a heartbeat, so the muscle has to pump harder to keep the blood moving. And then another cause would be heart muscle disease or cardiomyopathy or inflammation, so myocarditis. So this is damage to the heart due to maybe drugs or alcohol or even viral infections, and this can all increase heart failure. So then another cause would be severe lung disease. So when the lungs don't work properly, the heart has to work doubly as hard to get available oxygen to the rest of the body. Another cause are heart defects at birth, so congenital heart disease. So this is when the chambers don't form correctly and other body parts have to compensate for this and work harder to correctly for the incorrectly formed chambers. And then diabetes, of course, is a risk factor and a common cause because this increases the risk of developing heart failure because people with diabetes tend to have higher blood pressure and atherosclerosis. And then lastly, another cause would be sleep apnea. So this is just pauses in your breathing, and it can contribute to extreme tiredness and can also play a part in high blood pressure, heart failure yet again, diabetes, and then also stroke. So among all these causes of heart failure, high blood pressure remains a commonality within most of them, and it brings up the hormone of aldosterone. So aldosterone is a steroid hormone that that's secreted by the adrenal glands. So that's above your kidney, and it regulates salt and water in the body, and thus it has an effect on blood pressure And as I stated above, blood pressure plays a huge role in heart failure. So next slide. So let's put heart failure in perspective, at least in the United States. So between 2013 and 2016, 6.2 million adults in the US had heart failure. And also in 2017, about 13.5% of death certificates involve some mention or form of heart failure. And then in 2012, $30.7 billion went toward hospital costs related to heart failure within the US. So this would include costs from healthcare services, medicines to treat heart failure, and then missed days of work. And then also heart failure is common in people over the age of 65, African Americans, and women. Next slide, please. So let's talk about how aldosterone and heart failure are related. So we know that aldosterone is detrimental to heart failure because it contributes to retention of sodium. So having too much sodium in the body can lead to high blood pressure. And then also loss of magnesium and potassium. So this can cause cardiac arrhythmias and low potassium and low magnesium concentrations can often enhance the toxicity of drugs, especially for people who are taking medications for heart disease. So this is a major problem. And then another reason why they're related is the sympathetic activation. So this is when your heart rate is increased. So increasing output to supply your body with oxygenated blood. So the sympathetic activation is almost always activated, which isn't good. It's good in some scenarios, but you don't want your sympathetic nervous system to be acting on all stimuli. So then another important factor, kind of the opposite or the flip side of that, would be your parasympathetic nervous system being inhibited. So because your sympathetic nervous system is always activated. So they kind of go hand in hand there. And then the myocardial and vascular fibrosis. So this is when a significant increase in the collagen volume of myocardial tissues. It's triggered by either tissue injury from hypoxia, so not getting enough oxygen, inflammation, or hypertensive overload, meaning high blood pressure. So then there's also the baroreceptor dysfunction. So this is essentially fluctuations in your blood pressure due to episodes of severe hypertension. So it could be an elevated heart rate in response to stress, exercise, or even pain. So these are just fluctuations. It's a dysfunction in that aspect. And then there's also vascular damage. So meaning the buildup of plaque or the fat or the cholesterol. So that atherosclerosis that I was talking about before in the arteries and veins, this slows down or blocks the blood flow. So that's how aldosterone is related to heart failure. And then one more here. So it impairs arterial compliance. So essentially, arterial compliance is the ability of the arterial wall to extend or increase volume as pressure increases. So essentially, as pressure increases, the arterial wall does not increase volume. So this creates a problem. Next slide, please. So what stops the production of aldosterone? So we know that angiotensin converting enzymes or ACE inhibitors suppress the production of aldosterone. And we also know that aldosterone receptor blockers work as well, but they're not used as much in patients with heart failure because these medications are often contraindicated in patients with renal insufficiency, so kidney problems, or serum creatinine levels that are higher than 2.5 milligrams per deciliter in patients. And then also in patients with baseline serum potassium levels that are higher than 5 millimoles per liter. So that's why they're not used as frequently. But the conjunction of ACE inhibitors as well as aldosterone receptor blockers, we know that it can lead to hyperkalemia or increased potassium levels, which we don't want that. Next slide, please. So what do we know? We know that the use of ACE inhibitors only can reduce formation of aldosterone. And we know that spironolactone, so that's the aldosterone receptor blocker, in conjunction with standard doses of ACE inhibitors, has led to being pharmacologically effective. So with that being said, this decreases atrial natriuretic peptide concentrations, or ANP. And ANP is a hormone that's secreted from the right atrium in response to atrial stretch, so from fluid overload, essentially. So your body has too much fluid. So we know that it decreases that. And then it does not lead to serious hyperkalemia. So that's another huge finding, because we know that typically those used in conjunction together do lead to hyperkalemia. So in comes the RAIL study. So basically this study was used to test the hypothesis to treat daily treatment, for 25 milligrams of spironolactone in one group versus placebo. And we wanted to see if the 25 milligrams of spironolactone would significantly reduce the risk of death in patients with severe heart failure. Next slide, please. Okay, so as for eligibility criteria, was there anything, can you hit the, yeah, there we go. Was there anything in the eligibility criteria that stood out to you guys as you read the article or even the supplemental reading? You can put answers in the chat too if you're not comfortable speaking.
Anything expected or unexpected?
Well, one thing I can mention is that the study was done during the 1990s. So there was no mention of race or ethnicity. And we know, as I stated before, that African Americans and especially people over the age of 65, that there's a higher prevalence of heart failure within this population. So they didn't mention anything about race or ethnicity. So I think that's really important in the inclusion and exclusion criteria. But moving forward a little bit, so this is what the inclusion and exclusion criteria consisted of. So essentially there was the New York Heart Association. To be included, you had to have either a class 4 heart failure within 6 months before enrollment, and then diagnosis of heart failure 6 weeks before enrollment as well. And then also you had to be treated with an ACE inhibitor and a loop diuretic. So you're already taking these medications. And then the left ventricular ejection, so ejection fraction. So this basically measures the amount of blood that the left ventricle of the heart pumps out to the rest of your body with each heartbeat. So that was also considered. Then the treatment with digitalis and vasodilators were allowed. So digitalis is basically used to treat congestive heart failure, and it increases the blood flow. And then vasodilators, they open or they dilate your blood vessels. So they did allow that. And then also oral potassium supplements were not recommended unless people developed or patients developed, or yes, they had hypokalemia. So that was inclusion criteria. And then as for exclusion criteria, so they had primary operable heart disease. They had to have congenital heart disease, as well as unstable angina. So if someone had unstable angina, they were not included, as well as primary hepatic failure. They had active cancer, any life-threatening disease other than, of course, heart failure. If they had a heart transplant, and then the serum creatinine concentration levels. So if it was more than 2.5 milligrams per deciliter, and then a serum potassium concentration of more than 5 millimoles per liter, and then as well as potassium sparing diuretics. So that was the inclusion and exclusion criteria. So based on that eligibility criteria, is there likely to be generalizability? Yeah, Janet said, I would not expect race to be mentioned in eligibility criteria. I agree, yeah, because the study was done. Oh, just in general, she doesn't expect it to be. Okay.
Yeah, I expect
Mhm.
it to be in a baseline table,
Mhm.
and perhaps more thought to what the population, and maybe recruitment efforts, but I wouldn't expect it to be an explicit eligibility criteria or criterion, but maybe you meant more something that whether there would be, like, I think one thing that was different about the COVID vaccine trials, is they really focused enrollment to make sure that they had a representative group. And I do believe the Moderna trials were even slowed down a little bit in terms of recruitment to make sure they had a representative population.
Yeah, that's a good point. Mentioning the COVID trials as well. Yeah.
So perhaps the population enrichment could have been useful here in
Mhm.
the recruitment process.
And well, maybe that is something that needs to be considered now that would have not been considered in the time when this trial was designed in large uh, trials like these with clinical outcomes, which could, and it have important clinical implications.
Right. So yeah, just kind of I guess going on to this question now. So is there likely to be generalizability? Um, I know Janet, you mentioned the clinical population or just clinical practice in general, but it's just kind of mentioning like age differences here, and how we know that people with heart failure are typically people who are older, age 65 and older. So keeping that in mind, the trial population versus in like a clinical real practice, how the age would is if that would be generalizable, not too sure. But also there are higher number of events in a high risk population. So that's also something that we want to consider, that the trial is powered by the number of events that occur. Go to the next slide if there's no other thoughts. Okay, so patients, this is now into the procedures. So patients were randomly assigned to using the double blind method. So to receive either 25 milligrams of spironolactone once daily or a matching placebo. And after 8 weeks of treatment, the dose was increased to 50 milligrams once daily if patients had heart failure symptoms that were progressing and getting worse without hyperkalemia. So serum potassium measurements were taken that following week. So after they increased this dose, after 1 week after the increased dose, to make sure that there wasn't any hyperkalemia, that they were checking for it at least. And then if hyperkalemia was developed, the dose was decreased to 25 milligrams every other day. And as for serum potassium measurements, they were taken every 4 weeks for the first 12 weeks, and then every 3 months for up to a year, and then every 6 months until the end of the study. And then there were also clinical laboratory tests that were conducted at week 1 and also at week 5. And then it's also important to mention that the study medication was withheld if there was, once again, serious hyperkalemia, or if the serum creatinine level was 4 milligrams or higher, for 4 milligrams per deciliter or higher. if there was an intercurrent illness or any other condition that was medically necessary to protect the patient's best interest. Next slide, please. So can you just click once? Yes. Okay. So what was the primary endpoint for this study? Can anyone tell me what the primary endpoint was?
All-cause mortality.
Yep, that's correct. Can you just click once, Jasmine, and then one more time? Perfect. Okay. And then how about the secondary endpoints? There were about 3 or 4 here. Can anyone mention what they were?
Death from cardiac causes,
Mhm.
for example.
There are, I think, 3 more. Does anyone want to give it a whirl? Just take a guess.
And there is also hospitalization for cardiac causes, the combined incidence of death from cardiac causes or hospitalization for cardiac causes, and a change in the NYHA class.
Right. Okay, Jasmine, you can click. Perfect. Then can you click one more time? Awesome. Okay. So yeah, as you guys mentioned, the primary endpoint was death from any cause, and then the secondary endpoints were death from cardiac causes, hospitalizations from cardiac causes, the combined incidence of death, either hospitalization or cardiac causes, and then once again, we said this, so the change in the New York Heart Association class. So those were the endpoints for this study. And then the effect of spironolactone was assessed using pre-randomization variables, and there were 6 here. So they included the left ventricular ejection fraction, the cause of heart failure, serum creatinine concentration, age, the use of ACE inhibitors, and the use of digitalis. So could you go to the next slide? So this question here, so what's the importance of pre-randomization variables? Or I guess, in other words, why would you want to specify your variables for your analysis phase?
There may be baseline differences among the populations. Some have worse ejection fraction, or some are on multiple medications.
Mhm.
So you want to control for their baseline status.
Yep, exactly. Any other thoughts?
And if maybe we want to do a stratified randomization, so we may need to know the important factors that may influence the outcome.
Yep, definitely. So those are all great answers, and yeah, I definitely agree with that. So this was just kind of get everyone talking a little bit and see what everyone was thinking. But yeah, so the importance of that, of pre-randomization variables, and just having 6 in general. You don't want to have too many, because it's not practical to use a large set of variables just in a model in general. But yes, it's important to control for bias and things like that. So next slide. Okay, so just getting into a little bit of the statistical analysis. So Jasmine's going to touch more on this in depth, but I'm just going to mention what was done. So the Kaplan-Meier method that was used to address cumulative survival curves for the 2 groups, so the spironolactone group and the placebo group. And then the comparison between the groups, they used a log rank test. And then they also used a Cox proportion hazards model to explore the effects of baseline variables on the effect of spironolactone. And then there were also some sample size assumptions. So they mentioned that the mortality rate in the placebo group would be about 38%. So that was the first assumption. The second assumption was that the risk of death would be 17% lower in the spironolactone group, and that about 5% of patients in the spironolactone group would discontinue treatment each year of the study. And you'll see in the results coming up, some of these numbers, how they adjust to what actually happened. And then also the power was set at 90% with a two-tailed and an alpha level of 0.05. And then it's also important to mention that the DSMB, so the Data and Safety Monitoring Board, they evaluated for efficacy and safety at each of their meetings with the data that was available at that given time point. And then at each meeting, they also calculated the type 1 error with respect to efficacy. So next slide. Okay.
Yep, then I'll take over from there. And then I'll start with some questions. The trial's scheduled to continue through the entire year of 1999, but can anyone tell me why did it stop early? You can put in the chat or speak up.
It was early stopped because of efficacy.
Yep.
So the independent data monitoring committee, they conducted interim analysis and found that the intervention was more efficacious than the control. So they stopped the trial.
Yep, that's correct. So it's actually stopped on August of 1998, which is more than a year early than the scheduled date. So now the mean follow-up will be 24 months. So as Xiangji has said, it's also because of the observed effect exceeded the pre-specified Z values. So beneficial effects were proven. So that's why it stopped early. And moving on. So what are some of the considerations or consequences of early stoppage of a trial that you can think of, or any guidelines are usually used for early stoppage?
You want to make sure that you have evidence strong enough to support your efficacy assessment, and also evaluate the overall benefit and risks to get both the efficacy and safety outcomes.
Yep, safety is definitely very important. Anything else?
If they found, if they like terminated the trial because the drug was not efficacious, there may be a risk of false negative. So,
Yep, great point. Yeah, the general guidelines are usually based on safety, benefit, and futility. Safety, of course, the risk on participants will definitely outweigh the benefits, especially unexpected ones, and unexpected serious or severe adverse events. Benefit, like in this trial, that the study hypothesis is unexpectedly proven early within the pre-specified criteria. And usually futility too, where the hypothesis is shown to be unprovable within the constraints of the trial based on usually the interim analysis. And then, so we can move on to the results section, where this is our table 1. So we have a total of 1,663 patients recruited across 195 sites in 15 countries. So that's a very big international trial. As you can see from the summary, we have balanced characteristics between the treatment and placebo group, which is, again, one of the RCT characteristics. And it's also actually important to note that most of the patients here are white males. one thing to important to note in the study. And then another thing that the paper pointed out is that 435 patients discontinued treatment, similar numbers from each group due to reasons like lack of response, adverse events, administrative reasons, and need for heart transplantation. So 2 from the placebo group actually died after heart transplantation. And then we'll talk more about adverse events and safety later on. And after the trial, the mean dose of study medication in the placebo group is 31 milligrams and 26 milligrams for the treatment group. So next we see here is the Kaplan-Meier curve, which shows the probability of survival between the 2 groups. There are 386 deaths in the placebo group and 284 deaths in the treatment group. So you can see that a higher percentage of deaths is from the placebo group. And then next we have our table 2. So Cox proportional hazards model is used here, like as Morgan mentioned earlier. So we have a relative risk of 0.7, indicating that there's 30% reduction in the risk of death. The paper also included cardiac causes, other cardiovascular causes, stroke, non-cardiovascular causes, and reasons of hospitalizations in the table 2. So out of them, the paper highlighted the cardiac cause of death. So it has a relative risk of 0.69, which also can be interpreted as a 31% reduction in the risk of death. This can be attributed to lower risk of death from progressive heart failure and sudden deaths. And then we did the subgroup analysis here, where the reduction of risk of death are similar across the groups. As Morgan mentioned earlier, 6 of them are pre-specified, and then additional ones are done retrospectively, which are according to sex, the New York Heart Association classification, baseline serum potassium concentration, use of potassium supplements, and use of beta blockers. We can see that the estimates lie on the left side of the figure, showing that there is reduction of risk of death in the treatment group. From our table 3, it shows that the relative risk of a combined endpoint of death from cardiac causes or hospitalization for cardiac causes is 0.68, so a 32% reduction in the risk of death, which are all significant as well. So lastly, we have our table 4, which is on adverse events. Something that worth our attention is gynecomastia, or breast pain in men. So 10% of the men in the treatment group reported the symptom. So, and only 1% of them from the placebo group. So this caused more patients from the treatment group to discontinue the treatment. And then at the bottom of the table, we also have serious hyperkalemia, which 2% reported the adverse event from the treatment group and 1% from the placebo group. So this extends to our question on the next slide. How would you balance the risk and benefits of the trial? If you're on the DSMB, would you stop the trial early, like what they did in this trial, or continue the trial considering you observe incredible benefit from the Kaplan-Meier curve and the estimates earlier versus the adverse events on table 4? There's no right or wrong answers. It's definitely open for discussion.
There's also an opinion in that supplementary piece for today.
Yeah, hi, this is Jay. I just mentioned that being served on many DSMBs. The question always comes, yes, the statistical criteria have been met, but will this be a persuasive paper when it's published? Will it change practice, or will practicing physicians say, well, they only had half the number of patients, and I would have rather if they went all the way to the end. So that's one thing. And the other thing is, it takes an extreme value by definition to terminate the trial. So we get an estimate of the hazard ratio, as Jasmine showed us. But is that a good estimate? Could it have been just a wild shot, extreme value? And should some method be used to shrink, not to necessarily to continue the trial, but to shrink that estimate to something that's more realistic? Unfortunately, nobody has ever been able to agree on what that method would be. And then it gets forgotten and nobody ever does it. So anyway, these are some, I don't think the committee made the wrong decision here, but to answer Jasmine's question, these are some of the things that might come up.
Definitely. That it kind of extends to my next discussion question on would you recommend a change in the clinical practice based on a trial that stopped early, especially given the risk? I guess you have to benefit if you want to understand more about the adverse events versus trying to get the data out early, given that this trial actually stopped like more than a year than early than the scheduled date.
So the answer is when you look at the risk, well, in my opinion, when you look at the risks, they're largely reversible with dose reduction or discontinuation. And when you look at the benefit, it's on mortality, which is substantial. And so, I mean, I think the DSMC their hand was forced. They had to recommend early stopping. And I do think that the study is persuasive that this is one way to improve outcomes in patients with severe congestive heart failure. So I don't know what's happened in clinical practice, but certainly I find it persuasive. I think the one thing that's stopping early that we haven't talked about deprives you of is long-term follow-up in some patients. And, you know, you may see late occurring adverse events that temper your opinion of therapy in some situations. However, here, you know, I don't think there's any way you would want to continue the study given a 30% reduction in mortality among the patients.
And also, just to bring up another article, so there's another study done after the publication of this clinical trial is that the rates of hyperkalemia actually went up, and it's associated. More people were prescribed the treatment, and then more rates of hyperkalemia was observed as well. So that's another discussion point or thinking point as well.
Yeah, to tie it back to what both Dr. Herson and Dr. Jabs mentioned, the study did lead to an increase in prescribing of spironolactone. And many of those patients were on ACE inhibitors, so we were seeing those interactions going on.
So it also brings up one other thing. These people, in the trial, they monitored very closely for hyperkalemia. And dose adjust, you know, they started at low dose, they upped the dose, they dose adjusted as need be. I think we often see in clinical practice that the adherence to the sort of rigid practice in the trial is less than perfect. And therefore, in this case, the side effects of hyperkalemia would go up because they're not watching as closely and they're not dose adjusting as carefully and so forth.
And if I were a clinician, I would also consider other potential options, drugs in the practice that may treat the same disease. So here in this trial, the intervention was compared to a placebo group, and the effect size is considerable, but we wouldn't know if it was, compared to an active drug, how efficacious it would be, and yes, of course, the balance between the the adverse events and the benefits.
And I think, sorry, just to echo what's already been said before, just in clinical practice, you'd have a discussion with the patient and you'd review the potential benefits and the risks. And I think in this case, gynecomastia wouldn't consider a significant risk. Serious hyperkalemia can be significant, but I think it's up to the clinician to monitor that appropriately with frequent blood work.
Any other thoughts?
Yeah, let's tie it back to the generalizability for a bit. What can we say about the actual participant population? Did you guys notice anything about those baseline measures? They were a bit on the younger side. At least that's what it seemed like to me.
They're mostly white and also males too.
Mm-hmm.
Yeah, I think that's where I should have probably brought the point in, not in the eligibility criteria, but the fact that, now that we know that African Americans are more susceptible to heart failure and patients who are 65 and older. So having the trial have, younger patients who aren't nearly as nearly at risk, kind of, it's not as generalizable, I guess I would say, yeah.
Any other thoughts from anyone? Okay, so wrapping up, the key takeaway is that spironolactone did reduce the risk of death and improve symptoms of heart failure in this trial. So, but then it's also important to note that patients in this study were higher risk than those in the studies of other medications on heart failure, but lower risk than patients in studies on enalapril. So, but the results were consistent with the understanding of effect of aldosterone in patients with heart failure. The treatment is likely to be cardioprotective, and reduction in the risk of hospitalization may be due to the ability of treatment to reduce myocardial and vascular fibrosis. And overall, the treatment is tolerated well. Most usually discontinue treatment due to gynecomastia or breast pain, especially among men, as we mentioned in the treatment group. But moving forward, we'll definitely need more research, especially for those patients who are lower risk than the study, such as less severe heart failure. So this brings to the end of our presentation. If there's any questions or any more thoughts to be shared, please go ahead.
I do have a question, if I could, related to the discussion earlier about the early stopping and the DSMB, and in particular, Dr. Herson's comment. So presumably here, they had pre-specified stopping guidelines. They had, I think they had a spending function. They had to have very significant evidence specified in advance in order to stop the study early. But Dr. Herson's comments about trying to balance the adverse event profile against, the desire to stop early, could there be a circumstance in which a mortality outcome passes a pre-specified early stopping guideline, but a DSMB would try to argue for continuation anyway?
Didn't that happen? Shariza, you know what trial I'm thinking of, the progesterone trials, and that is exactly what they did. Now, when I made that comment, Dave, I was not referring to just one trial. I was indicating that this often comes up. However, the decision is made, as Doug said, reversible side effects, whatnot, and they wind up saying, well, this is already persuasive, so we should stop the trial. The statisticians always want to stick to the statistical rules that you pointed out, and I would be one of them. But this is the kind of discussion that comes. However, I think, Shariza, you might want to mention, they went, what, 2 more meetings before they terminated the progestin trial, something like that?
They did. I wanted to bring up earlier too the timing of these meetings and the timing of the interim analyses. Those are very delicate decisions to be made as well with these aspects of both your intervention as well as your outcome and side effects to take into consideration.
Right. So anyway, what you're saying, Dave, is right. I agree. I'm just mentioning that we don't often see the discussions that take place in the background. We read the paper, the trial was terminated, but perhaps in this DSMB, there were some discussions along the lines that I made and that Doug made. But the right decision was made.
Yeah. So
Yeah. Certainly
having-
not disagreeing with that.
Yeah.
So having participated in trials in which there was an unanticipated mortality difference, I can tell you that the first time you see it, it's hard to pull the trigger at that moment. You want to go back and look at the data very carefully and make sure there's not a baseline imbalance that is leading to a confounded result. And it would be very hard to pull the trigger on the first meeting. The next meeting might be very soon thereafter, but I think unless mortality is your primary outcome and it's very clear that there's a difference, you really do want to analyze the data and make sure you're making the right call.
Sure, but so the reason I brought up the question, I think mortality was the primary outcome here. So that early stopping rule was premised specifically on looking at that mortality difference, right?
Yeah.
Yes.
Absolutely. But in the progestin trial, and maybe this is why it's discussed so much, people were dying. And nevertheless, it was a difficult decision for them, but they said, let's go one more meeting because we want the result to be persuasive. And I think that decision is still debated in a lot of places.
Yeah, and I completely agree. That decision is much harder in the case where mortality is not the primary outcome and you're looking at what could be a potentially spurious finding. You didn't design your study to look at mortality multiple times and properly account for that.
It's really interesting with this study too. I don't know if you guys noticed, they cut the data across many subgroups. So they wanted to make sure the effect that they were seeing was actually consistent.
Yeah.
Any other comments? All right. Thank you both, Jasmine and Morgan. Our next journal club is going to be on October 20th. Dr. Holbrook and Xianji will be presenting as well. And I think you guys already chose a topic, no cluster RCTs?
Yes.
Great. Okay. Take care, everyone, and hope you're surviving first term okay.
Yeah.
Bye-bye.
Bye.
Thank you. Bye.